Hello and welcome to this Health Foundation webinar, Spreading Innovation and Improvement in the NHS. We've had an incredible number of people sign up for this webinar, over 1,700, and it's great that so many of you have been able to join us today. I'm Tim Horton, an Assistant Director at the Health Foundation, and I'll be chairing the session today and also sharing some of the key findings from our recent Health Foundation report, The Spread Challenge. Now, how to spread new ideas and effective practices from one organisation to another is one of the key challenges facing the NHS today. I saw that the NHS long-term plan published last week says that almost everything in this plan is already being implemented successfully somewhere in the NHS. But how do we go from somewhere to everywhere? That's what we're here to talk about today. And to do that, I'm delighted to be joined by two distinguished guests who know a huge amount about spread and adoption. Amanda Begley, Director of Innovation and Implementation at UCL Partners, and also National Director of the NHS Innovation Accelerator. And Anna Burhouse, Director of Quality Development at Northumbria Healthcare, and a co-founder of Rubis QI, an organisation that supports teams in the NHS with innovation, spread and quality improvement. Now, there will be a question and answer session later in the webinar, thanks to those of you who've already submitted questions. And for those of you who haven't yet, we'd be delighted to hear from you. Please send in any questions you have by typing them into the box on your screen throughout the webinar. So I'm going to start us off by sharing some findings from our recent report, The Spread Challenge. For many years, the Health Foundation has supported teams in the NHS to innovate and to spread their ideas. And in this research, we had a chance to work with those teams and hear firsthand the real challenges of spread and adoption. Now, the starting point for our research was something we see a lot in healthcare. We called it the replicability problem. And this is that while it might be perfectly possible to do something great once in one location, very often when you try and replicate it elsewhere, it doesn't work out as well. This is something we see particularly with complex healthcare interventions that seek to make improvements in clinical processes and pathways. So checklists are an example of a type of intervention with a mixed record of success. If you take surgical safety checklists, for example, in some cases where they've been implemented, they've been associated with very significant reductions in surgical complications and mortality. In other cases, they've had virtually no impact at all. And what this replicability problem highlights is that adoption is often harder work than we assume. And that even when an idea has been successfully piloted, it can still take a huge amount of effort and creativity in order to make it work in a new setting. And I briefly want to highlight two reasons why that is. So the first is that complex healthcare interventions tend to be context sensitive. And by that I mean they're embedded in an organisation's systems and culture. They're dependent on human behaviour and relationships, and they're dynamic and they can evolve in different ways in different settings. Now, if an intervention depends on its context to work, then an implication of that is that an intervention might need to be adapted in order to fit new contexts, meaning that the same thing will look different in different places. So to take an obvious example, when an intervention is co-designed with patients, then local patient priorities will shape how it looks in any one setting. Something that our research highlighted was the sheer extent of adaptation that goes on when a complex innovation spreads. We asked adopters from the Health Foundation's programmes if they'd made adaptations to the intervention they were implementing. And as you can see from this slide, 8 out of 10 said they had. And of those, nearly all of them said that these adaptations had in some way been necessary in order to implement the intervention in their own setting. A second reason why adoption is often hard work is because of all the other things that might be required in order to implement the intervention successfully. And this diagram highlights some of those factors, which could be to do with the capabilities and skills required, or the method for implementing the intervention, or even the organisational culture required to make it work. So if we think about culture for a moment, sometimes people make the mistake of thinking that the technical components of an intervention are all that really matters and that the social dynamics that surround it are less important. But what we see in many cases is that the social can matter as well as the technical. The example you can see on this slide is Prompt, which is a multi-professional training course to help teams respond to obstetric emergencies. And this was developed by a team at Southmead Hospital in Bristol, where it resulted in dramatic improvements in care outcomes. But while Prompt has spread widely within the UK and internationally, in some cases teams have struggled to replicate the successes originally seen at Southmead Hospital. And research to explore this phenomenon has found that the success of Prompt doesn't simply rely on the technical content of the training, but also on factors such as the values, behaviours and learning culture within the organisations implementing it. So the social can matter as well as the technical. So to summarise the argument so far, we've looked at two reasons why adopting a new idea can be harder than we might think. First, because interventions might need to be adapted to their context, and secondly, because of all those other range of factors that might need to accompany the intervention for successful implementation. In the second half of my presentation, I just want to look at some implications of these two issues for how you might go about spreading or adopting a new idea. And I'll express these in terms of three takeaway thoughts. The first is to consider the right strategy for describing your intervention. How much has to be specified in advance, and how much needs to be left to the adopter, given their unique context? So you could think of an intervention description as being tight or loose. Tight descriptions attempt to specify as much as possible. So if you think about the example of Prompt that we've just looked at, there's currently a research project underway to try to characterise the norms and behaviours that need to be in place for successful implementation, and then to set them out as an explicit part of a training package. Loose descriptions, on the other hand, might instead specify the principles or goals, but then leave it up to the adopter to find their own way of fulfilling these. Tight descriptions, if you want, focus on fidelity to a particular set of components. Loose descriptions on the ability of the adopter to formulate their own version of those components in their own settings. And the best strategy to use will depend on the range of adaptation that might be required, or the extent to which you think the success of the intervention really resides in the specific components versus the agency and the capability of the adopter. This next slide shows an example of a capability building approach to spread, one that the Health Foundation is currently supporting, the Flow Coaching Academy. And this supports teams to improve patient flow along clinical pathways through coaching. It's an approach that was developed by a team at Sheffield Teaching Hospitals. And it's interesting, the Sheffield team's original work did result in a very successful intervention called Discharge to Assess. This is where a patient's discharged from hospital and has their needs assessed at home rather than waiting in hospital for that assessment. But the team are now trying to spread these kinds of benefits by spreading the capability and the methodology that underpinned their success, rather than focusing on spreading the specific intervention. My second takeaway thought is about the importance of capturing the learning from the early stages of the spread process and using it to refine the intervention. At the beginning of this presentation, we looked at how the success of an intervention can depend on its context. But the reality is that innovators can't always see their own context. When you've done something once in one setting, it can be hard to know which aspects of context have facilitated your success without really having anything to compare it with. So it's often only when something starts to spread that the kind of comparative information becomes available that enables the innovator to understand what made their innovation work first time round. And for that reason, the early stages of spread are often really about testing and learning. And they're a time when the intervention often undergoes substantial revision and refinement. So we asked innovators from the Health Foundation's programmes, would you say you've learned new things about your intervention from adopters' experiences of implementing it? And as you can see, 9 out of 10 said yes, and 9 out of 10 of them said that they changed the way they described their intervention as a result. And the contribution that early adopters make to refining the innovation really challenges the kind of traditional pipeline model of innovation, which sees knowledge as generated by the innovator and then transmitted to everyone else. In reality, innovation is often a much more distributed effort. And that's an important thing for an innovator to know going into work to spread their innovation. My final takeaway thought is about the importance of building networks to capture the learning generated by the spread process and to allow adopters to share their experiences and insights with each other. It's clear from what I've been saying about the challenges of adoption that adopters might need a range of support, and that could include, as you see here, training, funding, support with analytics or evaluation, and so on. But one key source of support, which you can see down in the bottom right-hand corner of this slide, is peer learning, the opportunity to share experiences and insights with other adopters. And this can be a major source of support for successful implementation. And peer networks are often an effective way of capturing and sharing that learning. It could be a network of adopters formed as part of a specific spread initiative, or it could be an established network like the Q community, which connects people with improvement expertise across the UK and is increasingly supporting them to share and spread their ideas. Interestingly, when we asked adopters from the Health Foundation's programmes what would have made the biggest difference in helping them, the most popular option was providing more opportunities to share learning. And that was followed by doing more to support readiness and allowing more time for implementation. So I'll finish by summarising those 3 takeaway thoughts. Consider the right strategy for describing your intervention, capture learning from the early stages of spread and use it to refine the intervention, and build networks that allow adopters to share their experiences and insights, which can be a major source of support for successful implementation. Thank you. I'm now going to hand over to Amanda Begley, who's going to share with us some of the learning on spread and adoption from the NHS Innovation Accelerator. Over to you, Amanda.
Thank you, Tim. I think you'll find that some of my insights very much resonate with what Tim's already presented. So the NHS Innovation Accelerator is an NHS England initiative, and it's delivered as a partnership between the country's 15 academic health science networks and hosted at UCL Partners. It supports NIA fellows to take their high impact innovations to benefit more patients and more NHS sites, and it also seeks to capture and share learning. In this presentation, I'm going to be sharing findings from 2 of our recent research reports. So firstly, we had an independent evaluation of the NIA commissioned by the Health Foundation and led by the Institute of Employment Studies. And the involvement of patients was identified as one of the most critical factors for innovation scaling. And that's around a number of areas. So firstly, it's about the innovation design and testing, particularly to demonstrate that the innovation is needed, it has utility, and it really delivers improvements that matter most to patients. A number of our fellows have really changed their spread strategies based on their feedback from patients about what matters most to them. The third area is in terms of lone innovators, NHS sites, small companies can really find it difficult to influence national decision makers. And what we found is that patients and also charities have played a really critical role in influencing senior decision makers, particularly with regards to highlighting and amplifying the need for an innovation and also helping to identify and seek support in overcoming barriers that can only be addressed at a national level. And then finally, as people on the webinar will know, driving innovation can often feel really lonely, and you can be faced with multiple setbacks. All of our NIA fellows have highlighted that it's the feedback from patients and carers that fuels their resilience and motivation to keep going. The second research report I want to talk about was published in November last year, and it was really looking at how my NHS sites take up innovation. This was delivered in partnership between the NIA and the Bayswater Institute and led by Laura Boyd, who's the Deputy Director of the NIA. And we really looked at, through an analysis of 9 NIA case studies, to identify some common findings. And we found 3 that really did help enable the uptake and embedding of innovation. And I'll talk about those 3 now. So firstly, the adoption journey, from very initial conversations and awareness of an innovation through to it being sustainably taken up. We found the process to be really iterative and non-linear. And in the report, we explain this by talking about a lock and a key. So the innovation starts out as an uncut key, which becomes embedded over time in the lock, which is the unique organisational context, through a process of mutual shaping, negotiation and adaptation, as we heard a lot about in Tim's presentation. The second element of the adoption journey is that to move along that adoption journey, there's a number of push and pull factors that we identified. On the left-hand side of your slide, you'll look at the pull factors, and these really relate to the adoption site. So they include things like recognising a need for innovation, awareness of the innovation, having key individuals that can motivate improvement. And then on the right side, you'll see the push factors, which really relate to the innovator and also the innovation. And it includes things like how adaptable is the innovation, the actual time that the innovator spends at the NHS site to support, and really the flexibility of the training that's offered to adopter sites and individuals within those sites. The second area is the adoption network, which I suppose highlights what is already well recognised in research and practice, is the role of champions. And what we found in the case studies is actually it wasn't lone champions, it was a network of multiple champions who were operating both inside and around the adopting organisation. And I like to describe this as these champions working almost as an orchestra, undertaking tasks both individually and collectively to really improve the fit between the innovation and the adopting context. And we also identified that these champions had a number of common traits. So they were really reflective on their current practice and really wanted to drive improvements. They had the ability and the confidence to act outside of their current and immediate roles and responsibilities, and they were very well connected within the local networks. The third area is about finding common tasks that were replicated time and time again across all the case studies, and those included a process of getting to know the innovation, building the local case for adopting the innovation, as I've already talked about, the process of adaptation of the innovation in the adopting context, and also working through how the innovation can be embedded and sustained. And throughout this whole process, what we saw was constant trialling. So trialling the innovation in different services at different points, and really thinking about how you can collect data for different audiences. And the report has three main recommendations. So firstly, adoption of innovation is really complex. It's really challenging. There isn't a blueprint for it. And as such, we must find ways to better applaud and celebrate NHS staff and organisations who do take the risk and take up these innovations, and recognise them for their resilience, their commitment and their tenacity. Secondly, we really need to think, as Tim has also highlighted, how we best capture and share learning across adopter sites and across networks. And finally, there's a lot of evidence base and theory to draw upon. We need to make sure that we do draw upon that in order to guide our adoption processes, but also how we share those insights across sites. And in terms of my three top tips, firstly is, as I said earlier, the involvement of patients and carers is really, really important. It provides direction, it helps influence and engage a wide range of champions, and it really can't be underestimated in terms of the role that patients can have in driving the innovation, adoption and spread process. The second area is, historically, what we've tended to do is try and make adoption sound really user-friendly, really easy, in order to encourage as many people to adopt a particular innovation as possible. We simplify things into nice little how-to guides, but what this is actually is quite counterproductive, because a few people try it, they fail, and then the whole engagement with the innovation drops off. So what's really, really important is that we recognise the complexity of adoption, that we draw on the evidence base, and that we really recognise there's a lot of adaptation and trialling that's going to be taking place, and just be really open and honest about that. And the third area is that what we know from innovation adoption is you can't have a transactional relationship between adopters and innovators. It's a long-term partnership, and it's a long-term partnership with a wide range of multiple champions who can then wrap around support and a wide range of skills and perspectives to enable the adoption process. Thank you.
Thanks, Amanda, for that fascinating presentation. And it's great to see some of the learning that's coming out of the NHS Innovation Accelerator, as well as all the work you're doing to help scale healthcare innovations.
Thank you, Tim.
We're now going to hear from Anna Burhouse, who's going to share her insights on spread and adoption through the lens of the Precept project. Over to you, Amanda.
Thank you, Tim. We just thought you might like to hear a lived example of adoption and spread. So about 10% of extremely preterm babies will develop cerebral palsy, and until recently there was no way to prevent this from happening. And in 2014, when I was Director of Quality at the West of England Academic Health Science Network, Dr. Karin Loit, a consultant neonatologist, proposed that we roll out an innovative approach to try and increase the prevention of cerebral palsy across the 5 maternity units in the West of England. Our original aims were to try and reduce the risk of babies being born with cerebral palsy, to reduce the unwarranted variation that we could see in clinical outcomes across the 5 sites, and we also just wanted to be as good or better than the world leaders in the US and Australia. So we tested this concept with key stakeholders, and before we even got started, we generated lots of local support. The West of England AHSM board approved a small budget for implementation, and a chief executive from one of the adopting hospitals agreed to become the programme sponsor. We also worked closely with Clark West to develop a robust evaluation framework. And why was this important? Well, the Cochrane Collaborative meta-analysis had been published in 2010, 4 years before, and it had already strongly proven that magnesium sulfate was very effective, and yet the uptake still wasn't very strong. And in addition, the economic case was strong too. I mean, how can you quantify for a family the impact of having cerebral palsy or for the individual? But in terms of the healthcare costs, the cost of giving magnesium sulfate is about £1 a vial. But the healthcare associated costs are over £800,000 per individual, and that doesn't include social care or education. So with really strong clinical evidence and really strong economic evidence, it's really hard to understand sometimes why things don't get adopted. So one of the first things we realised was that just presenting the evidence and giving people the means wasn't enough on its own for rapid adoption. And we really didn't want Precept to take 17 years to adopt, which is about the national average. So we learnt it was much more effective to use both hard facts that we took from the evidence base and put these in graphic and visual forms, and also to appeal to people's emotions through stories. So we created a whole range of leaflets and infographics, and we also worked with the preterm charity Bliss and with women who had had experience of preterm birth to tell clinicians their story about why this was also important. And this is an example of one of the infographics that we created, which basically tried to tell the whole story about Precept on one page to get the message across really clearly. And as Tim has already said, the context of adoption is really critical. And we knew that each of our 5 hospital sites was very different and had its own very unique environment, culture, and clinical microsystem. So to have simply imposed a single way of implementing Precept wouldn't have worked. So we trusted that the adopting sites would know their own systems much better than we did and find the best ways of making this work. And we used 5 Precept champions to implement this in the local sites. However, we did develop some collective practices. We produced a simple Precept quality improvement pack that contained tools and ideas about how to implement. We trained the Precept champions in it, and we created a shared measurement framework to capture our collective success. We also co-produced a range of clinical materials so that the adopting teams could use them if they wanted to make these practice changes easier to remember. And over time, we found that the adopter sites started to generate further innovations and share these ideas between themselves. So they included generating Precept newsletters and having local communications and local celebration events. There was a handy box with all of the Precept materials in one place so people could grab it and go. There were Precept branded pens and badges to give to people that had been trained to show this spread in a very visual way. And a lanyard that had the clinical guidance written on it so that people knew what the loading dose was. And also Precept magnets to put on delivery suite boards to show which of the women were eligible. All of the sites found that staff training was absolutely critical for success, but it was really interesting to see how the different approaches evolved. Some teams added the training into routine training slots, but quite a few sites developed what they called T-trolley training, where they actually took the training out to people in their working day and also on the night shifts. And they gave people a cup of tea and a slice of cake whilst they learnt about the new procedure. And we helped by providing the Precept champions with very cheap tablets with preloaded training materials that they could take with them, which made the training really, really portable. So as Amanda said, we found that it was really important to celebrate the incredible creativity of the adopting teams. They came up with so many great ideas, and really importantly, they helped the originating team at St Michael's Hospital improve their performance too. And we celebrated their success regularly at meetings and through blogs and conferences. And in 2017, we published our results together because we wanted to give formal recognition of the importance of the adopters' contribution to the success of the work. So, what did we achieve? In under 4 months, we trained 664 staff. Of the women that came through the doors during those 4 months, 88% of women received the treatment as planned. And we also learnt an awful lot about why 12% of women didn't get that intervention. We managed to influence the national data set to include whether magnesium sulfate has been given or not, which means that we can now measure this nationally across England. And we're really pleased to say that this is now in NICE guidance and also in the NHS long-term plan. And you can see from this graph here that all of the 5 hospitals that we worked with were in the top 10th percentile nationally several years later, to show that even though it was a very quick improvement programme, the change has been continued and has been embedded. It also shows from this graph the work to be done, because there's huge variation of outcomes nationally, and so we want to get everybody up into and using this regularly. And I'm pleased to say that we're able to do that because the Health Foundation have now granted the Precept team a Scaling Up award to roll it out to more sites. And also the NHS network has received funding from NHS England and NHS Improvement to make this a standard practice in all maternity units in England through the Maternal and Neonatal Health Patient Safety Network. So, never would Karen and I, at the beginning of our conversations, have believed that we would be able to see Precept grow and spread in such an amazing way. And our profound hope is that this will lead to a nationally statistically significant reduction in preventable cerebral palsy.
Thanks, Anna. It's really inspiring to hear about the spread of Precept and the impact that it's having. So, now you've heard from all of us on what we think are some of the key challenges faced by those spreading innovation and improvement in the NHS. We each drew out 3 tips in our presentations, and you might have also noticed we talked about the importance of allowing sufficient time for adoption as well. So we've collated these into a list of 10 tips that I'm going to put up now. So these are our top 10 tips, and I'll put them up again at the end. Now, I've got a couple of questions I want to put to Amanda and Anna, but before I do that, can I please remind you, keep sending your questions in using the box on your screen. So, Amanda, throughout our presentations, we've been offering some general advice and we've cited some examples to learn from. But to what extent can you really replicate someone else's spread strategy?
So I think what's really important is learning from case studies and from evidence-based frameworks that are available. They help almost give a checklist for things that you need to consider in developing your plan. But what we know from the NHS Innovation Accelerator is that every plan is bespoke. Unfortunately. So you need to do a lot of work in bringing your plan together, and we've sort of identified 4 areas that you need to think about in developing your plan. First of all, what need is your innovation or your work addressing, and how is that a local or national priority? So sometimes with something like diabetes, you're more likely to get in contact with a clinical commissioning group, but if you're looking at addressing a rare disease or a rare incident in terms of safety, often you need to start by really amplifying the problem or the need that you're trying to address. The second area is the nature of the innovation itself, and there's a lot of published work around what are the characteristics of innovation and what enable or don't innovation being taken up. So things like how trialable is it, how adaptable is it, as we've already talked about a lot. Are there observable results very easily? And I suppose you also need to think about the cost of your innovation and the business model. So is that going to be an enabler, or is that something you need to really focus on in your spread plan? The third area is you're adopting context. So your spread strategy will be very different if you're engaging with clinical commissioning groups, or engaging in provider trusts, or engaging in primary care, GP federations. And so you need to think about the context or your audience. And for example, in acute trusts, what we find is they often have, and well, maybe not often, but there is a bit more flexibility sometimes in the budgets because they are much bigger scale. But the number of committees and decision makers is much bigger. So you really need to factor in that time of engagement. And when you compare it to example for a GP practice where speed might be, in terms of decision making, might be quicker, but the budget availability might be less. So thinking about your adopting context. And then you need to think about the national context. So are there enablers or hooks that you can put your innovation on? Is there area that you're addressing in the long-term plan? Is it something that CQC look at in terms of their regulatory framework? Are there key figures like national clinical directors that are talking about the work that you're seeking to, or the need that you're seeking to address? So, and are there financial incentives that you might be able to attach your innovation to? Similarly, there may be some barriers that exist at a national level, and you need to think in your spread track plan about how you work through those. So I think there's a mix of do learn from these common issues and use them as a checklist, but do put the effort into developing your own spread strategy.
So there's no substitute really for doing the research and developing
sadly.
the tactics to engage with your own unique set of stakeholders and interests and structures as well.
Absolutely.
And tell me, what difference does it make whether the innovation is commercial and is being sold into the NHS or not?
So we have a number of different types of innovations in the NHS Innovation Accelerator, so we've learned quite a lot about this. I suppose 2 points to make. Firstly, in terms of commercial innovations, they tend to be more products, or at least have a product element to them. That might be digital, it might be medtech, and they often tick more of the boxes in terms of what are the characteristics of an innovation that's more likely to spread, because you can see it, you can play with it, you can see the results of using it, how it's different from existing practice. Whereas what we find with non-commercial innovations is they tend to be new pathways of care, new models of care, and they often are they're a bit more complicated to describe. They have a number of factors and features to them, but what they do tend to be is they tick the box around adaptation. So there's more options to adapt an innovation within a local context. The second area is probably to talk about the infrastructure and the business model. So with things like the reports like the Accelerated Access Review and the industrial strategy, what we've thankfully seen is a real increase in the support that's available for commercial companies to drive their innovation, and that's very well received from those working within the health sector. Sometimes it's difficult to navigate and there are still some gaps, but it is there and growing, which is fantastic. Unfortunately, we haven't seen the same kind of growth in the support for those trying to drive non-commercial innovations. So there's not a lot of support out there. I mean, the Health Foundation and the NHS Innovation Accelerator recognise that, and we're doing some early work to scope what is out there. What's really positive is 3.119 from the bullet point in the long-term plan shows a real commitment to growing the support that's available to use non-commercial innovations to drive outcomes. So we're looking forward to being involved in that and thinking about how the country can benefit.
Yeah, it's interesting. So at the Health Foundation, a lot of the innovations we're supporting to spread are similarly non-commercial. And there are particular routes in for those, so it could be through collaboratives or maybe working with a professional body like a Royal College. But that point you've made about the lack of infrastructure and support, I think is a real one. So it's encouraging to hear the news from the long-term plan. Anna, I was going to ask you, earlier on you talked about the importance of winning hearts as well as minds in making the case for adoption. Could you tell us a bit more about this? And in particular, what role do patients play in this?
Yes, so I think it's really important to think about heart and mind when you're thinking about adoption, and that's because we're not entirely rational all the time. So sometimes when you just present the facts, that's actually not enough of a motivation to get people to change. So this is very much about the psychology of change and how you get people enthused and want to do the change. And really then you're trying to play to their intrinsic motivation. You know, why should they change what they've been doing for a long time, which has maybe become a habit and is the easier thing to do, to then go and do something new. So I think there are many ways in which you might kind of want to encourage that in your adoption plan, and I would really stress the importance of having a really clear, both a stakeholder kind of plan and also a communication plan to help with that. And I think the particular role that patients play in all of this is, in my experience, they keep you very grounded about the purpose of this. Why are you doing this innovation in the first place? They're very good at telling you whether you're on the right track, and in my experience also brilliant at telling you when you've gone off track. And particularly for clinicians, if people hear a story that comes from a patient, they have an emotional response, and again that really helps with the intrinsic motivation about wanting to change.
I think with a lot of adoption where it does involve behaviour change, it's hard. You know, we often hear stories that, of course, the robust data about the evidence is needed to make the case to adopt.
Yeah.
But then what tips something over from recognition of the case into actual motivation to act is a sense of that human impact.
It is. And I think the other role that patients play is they are innovators in their own right often, patients and carers. They will come up with ideas that you haven't thought about. And certainly in every single piece of work I've done around this, I've seen that to be the case.
Great. Thanks, Anna. We're now going to turn to some of the questions that those of you watching have sent in. And a lot of viewers were interested in how to get buy-in from colleagues for adopting an innovation. So our first question, which comes from someone working in the hospice sector, is does the panel have any advice on how to gain buy-in from clinical colleagues for adopting an innovation or a new way of working, including colleagues who might be sceptical or even fear change? Anna, let me come to you first.
Well, I'm a clinician, and I know that for most NHS clinicians, you really want to do the right thing, but sometimes you're busy and you're going to need kind of time to get used to a new idea. You want to question the evidence normally and find out, is it strong enough? Am I going to be doing the right thing? You also then want to think, what's this going to do or mean that I have to stop doing in a different way? So I think the emphasis then on the adopter is to try and convince people that it's the right thing to do. There are easy ways, if possible, to get it done, or even if that involves having some difficult decisions about some things that need to stop in order to make it happen. And I think then the other factor that clinicians often will look for is peer influencing. So I have a bit of a pet theory. I call it the silverback theory, and I think in clinical teams you often have very influential figures. That could be the receptionist, that could be a medic, it could be somebody else. But they're maybe the people in the peer group that will have a really big social influence on that group. So I've often learned, go and talk to those people and then they will talk to others, and then that effect kind of ripples through.
Yeah. Amanda, did you have any thoughts on this?
So that's really insightful and really helpful tips there. I suppose from my experience, probably my not so great findings, is it's really, really important not to assume that you understand what the real reason is for why someone has concerns about taking up an innovation, because we tend to go in with the immediate thoughts, and actually what we find is there's something really different underpinning that. So I think be open and listen. One of the things we have found in the NHS Innovation Accelerator is that innovation is considered as risky. So one of the things we've been trying to do is think about how do we de-risk innovation, and I did a blog a while ago on using kind of the SAFER acronym. So just briefly, S is about how do we share risk, A is about the adaptation piece, so particularly things, how do we use quality improvement techniques like try it once, review, try it 3 times, and have a really systematic approach for how we adapt an innovation in a way that people feel comfortable with. F is your followers. So you don't always want to be the first person who's doing this stuff. So if you know that other people are doing it, and particularly if you see them as credible, it's quite good to build your followers. The fourth one, as you've already touched on, is the evidence base. It's an obvious one, no-brainer, but we need to really think about have we got the right evidence for the people we're trying to influence. And R is regulation. So have we gone through the right regulatory processes? So I think de-risking is really important.
That's really helpful. I mean, just thinking about the adaptation aspect, if there's going to be work done to iterate and test a new idea, it might involve an element of co-design, and it's thinking, can you get those clinical colleagues involved in the co-design there? That can help build confidence. One other issue is skills as well. If I mentioned the importance of capability building earlier, and if there's a skills issue where people will need training in order to make the intervention work, whatever it is, and in particular for it to be used safely, then that's got to be a key element of the plan, including protecting time for that training.
I've also found that if somebody is fearful of something, if you can help them to articulate it and say, okay, you're worried this is going to happen, so let's measure it.
Yes.
And you use your measurement framework, and then sometimes people are worried for a correct reason, and if you're measuring it and they're right, you go, you were right, let's stop. And so measurement can be a really helpful kind of tool for clinicians to kind of help people take that adventurous step towards something a bit new.
Great. Our next question comes from a CCG board member in Bradford. Does the panel have any advice on implementing digital innovations? Amanda, let me come to you first.
So I would go back to the earlier point of make sure you've got a bespoke strategy, but I think digital in particular is we're quite new in adopting innovation around digital platforms, digital services, and I think there's a couple of really helpful documents to look at that have just been recently published. Both of them are tools for patients, for clinicians, for commissioners, and also for innovators to help them think through the sort of approach they need to take in developing digital innovations and adopting them and spreading them. So first of all is NICE's Evidence for Effectiveness report, which really helps people to categorise the type of digital innovation and then use that categorisation to decide what level and type of evidence does this innovation need. So for example, if you've got a digital innovation that's about monitoring somebody's health, it needs a different level and type of innovation to a digital innovation that's saying, I'm going to diagnose or help treat a condition. So that's a useful tool. In conjunction to that is the Department of Health and Social Care's Code of Conduct. And this really sets out a number of principles for the development and use of digital innovations, and also sets out a number of government commitments really to help us safely, but also at pace take up some of these innovations. So I would definitely recommend looking at both of those, and also to highlight they're actually out for kind of consultation and feedback at the moment. So if you feel that things aren't being addressed that you're concerned about, do feed those back.
I guess another point is, depending on what the innovation is, there might be some technical issues to consider.
Yes.
So compatibility with systems in the setting, or data sharing and information governance requirements. But I think one lesson that's come out to me from my engagement with digital innovation is it's only partly about the tech, but it's also about everything that surrounds it.
Yes, yeah.
What is the intervention? It's the use of that technology in a pathway.
Yes.
And using it effectively might therefore need some pathway redesign. It might require evolving new ways of working around the innovation in order to derive the benefits of it.
Yes.
So the recent National Institute for Health Research evaluation of online consultations and video consultations at Barts London flagged up. It was actually a lot more difficult than anyone thought to actually embed this stuff in a pathway. So I guess that'd be a point from me. It's not just about the tech, it's about the whole set of change that surrounds it.
Definitely.
Let's go on to our next question. And it comes from an oral surgeon in Hampshire. What culture change do we need to make innovation and spread easier in the NHS? What are the biggest cultural barriers and enablers? Anna, you go first on this one.
I guess for me, and I may be coming from quite a clinical perspective, but I think we're very good at generating really strong clinical evidence, and then we're quite good now at putting it into policy or into guidance. And then we kind of almost think magic will happen and it will just kind of by osmosis get into our system. And I guess for me the biggest clinical or a cultural change would be, let's think a bit more about that space, and let's not just assume it will happen, and let's give people the skills that they need, the capability and the capacity and the time, and acknowledge there is sometimes a cost to getting clinical things into practice, and also new innovations into practice.
So I suppose I'm always a bit of a glass half full type of person, internal kind of optimist. So I think when we've seen it a lot in the long-term plan is the creation of things like the integrated care systems, and I think they provide a really exciting opportunity to think about the take-up of innovations at population level, and I'm hopeful that they will help drive particularly innovations around prevention of health and earlier intervention, because we'll be starting looking at using a budget for a population, and I think that we'll start to see some enabling factors that we haven't currently got in the current kind of payment and reimbursement system.
Yeah. That's interesting. I suppose another cultural issue is just the recognition and the celebration of successful adoption as well as innovation.
Yes.
So it's great that there are schemes to recognise successful innovators and the huge impact they make.
Yes.
But actually, if part of deriving these benefits requires successful adoption at scale, then that's a much larger effort too.
It'd be lovely to see a national award for adoption, wouldn't it?
Well, there we go. We've our first policy proposal. Now, we've had a question through There's an Academic Health Science Network national workshop going on today. Hello to everyone there. And we've had a question through from them. Anna, the spread of Precept sounds very linear and structured. In reality, how did it feel? And knowing what you know now, what would you have done differently?
So it's always hard when you're presenting something, particularly in 7.5 minutes, to not skip over all the complicated bits. But there definitely were them, and it wasn't as linear as it sounds. And a really good example of that was, whilst we could provide some funding for the Precept Champion backfill time, the reality was that in one of the units, for instance, it was really hard to source the midwife to do that role. So having money enough, wasn't just enough to do that. So absolutely, it was a bumpy journey, and there were lots of kind of unexpected twists and turns to the story. However, when I look back on it and I think, what would we have done differently? I think the main thing I would say about that was that I think we could have spent more time drawing out more qualitative learning from the sites about exactly how hard it was to do, exactly what barriers they faced, and also the success that they had along the way and how they achieved it, and at what cost. Because undoubtedly a lot of the success of Precept was down to those clinical teams who gave above and beyond whilst also doing a really busy job.
That point about it being a bumpy journey,
Yeah.
I guess, is really important. Very often we have a spread initiative in the NHS because a solution's been identified, and there's a sense of, right, why can't everyone do this now? Perhaps without the recognition of the hard work involved in adapting it, in iterating it, that it will be a journey. And even the most successful projects encounter setbacks at some point. So I guess that's a really important message for people out there to have.
And also, I think it's really important to remind people it's continuous improvement. So how do we keep that performance at that level once we've got it? So the story doesn't stop when you do something like this. Actually, Karen Lloyd will still phone up those 5 units and say, have you seen your data?
Amanda, did you want to come in on this? Let's go to the next question then. It says, how can we best get a focus and not have it derailed on long-term prevention and transformational work, as outlined in the 10-year plan, when the pressure to create efficiencies quickly is ongoing and always there? I mean, I guess it's an obvious point in a way, but given the current environment in the NHS, there'll always be an immediate focus on operational pressures combined with a desire to do long-term transformational work. And that can require a real ambidexterity from the leader of an organisation. It'd be nice if there was a win-win answer here, but actually very often it's managing those two processes together. And I think for a team trying to do this kind of transformational work, that's really going to put a premium on the leadership of an organisation to give them the confidence to embark on that and to provide them with the resources and the air cover when things get tough.
Just, I suppose, as I said earlier, I think integrated care systems are going to allow us to start thinking more about this long-term and prevention. What we've found, particularly through our atrial fibrillation programme, is that we spent the first year probably just engaging and amplifying the need. That if we actually took a long-term focus on atrial fibrillation, we could, over the next 3 to 5 years, see a reduction in AF-related strokes, which will make a huge financial benefit to not just health but also social care. And we were able to undertake that piece of work by really saying this is the right thing to do. These are evidence-based interventions. And we also did some economic modelling to help people understand for their own budgets at what point would they start seeing a return on their investment. So I think amplifying that need and helping people think through the economic benefit. I suppose there's also the point about the portfolio. So you probably couldn't, in the current climate, have a portfolio that's all about long-term return. But there are things, I think, where you can get some of that air cover by delivering things, like 4 months in, you've delivered something, versus having a balance around some things that are going to be slower. But the prize in year 3, 4, 5 for the population is huge, significant. So maybe there's something around finding that right portfolio.
And I think for me this question highlights the skills that leaders need as well to recognise that adoption and innovation
Extremely.
are tough and they take time. And you know, to recognise the pressure that leaders will be under to balance that need for short-term outcome versus long-term gain.
A lot of pressure.
We've had another question through. Could you expand on how important co-production, patient engagement and involvement are to spread? Anna, you talked a bit about that. Anything more to say?
I guess I'm totally biased because I just think co-production is a really exciting way to do this. It brings a lot of energy into the system. I think as well, when you really do co-production in a way that allows you to think not about just about co-production but also about co-delivery, you start to think of really innovative ways in which we could change the NHS. So another piece of work that I've done around the 7Y Recovery College is really much about this agenda. It's about trying to work with people with lived experience of mental illness to think about how do you help other people on that road to recovery. And that has really changed the way that we work. So I think it's an exciting space. And I think we should do more to think about the skills that are needed for people in the NHS to embrace that way of working. And also recognise there are quite a lot of barriers. So, for instance, the HR process is sometimes about employing somebody. You might need some thought. So there's quite a lot of changes and adaptations you need to make to NHS infrastructure in some ways to really get co-production kind of really truly embedded.
That's interesting. Amanda?
Just to share an example, there's a number of examples in the NHS Innovation Accelerator, but I think that this example is great in terms of people rethinking their spread strategy. So Craig Newman is one of our NIA fellows with EPSMON, which is a digital tool to support people with epilepsy. And they had some fantastic data. So when they first came onto the NHS Innovation Accelerator, the pull for us was about the fact that they'd seen a 50% reduction in avoidable deaths associated with epilepsy, which was really clinically engaging and engaging from a commissioner perspective as well. But and that whole innovation had been developed with patients and charities, but Craig got more and more engaged with the charities. He was going out raising awareness of this innovation, and people were coming up to him saying, "Oh, fantastic, I think this will be really right for my friend because she's got a different type of epilepsy to me, not really relevant to me." And actually he was saying it was sort of relevant to everyone, so the messaging just didn't resonate. And so then rethinking with those charities and patient groups, what they've done now is focus on helping people to manage their seizures, because that was what was mattered most. So their research efforts, their redesign of their innovation, you know, a year, 2 years in, has been absolutely focused on, we need to make sure this is of value to our users, and the messaging needs to reflect that, our research efforts need to reflect that, and the design and iteration of our solution needs to reflect that. So just sort of one example of how you think you've got it right and you might have to one audience, but actually you need to really focus on patients and carers and their views.
I mean, you both touched on the notion of patient communities.
Yes.
And I guess it's interesting in a variety of areas we're seeing the growth of and the interest in patient networks and patient communities, often in a condition-specific way, but not necessarily so, for both articulating needs and the innovations that are required, and also being networks to disseminate and drive spread as well.
Absolutely.
Because ultimately there'll be some healthcare innovations which are not spread by managed processes within the NHS, but amongst users.
Yeah, and I think it's interesting as well to think about other ways of doing this, like crowdsourcing. You know, certainly in some of the teams that I'm coaching, there's a great example from a team in Southampton that are working around cochlear implants, where they put out on social media, help us with your ideas. So they were crowdsourcing straight through Twitter to help them with their innovation.
I think it's really exciting. Over the last year, the Health Foundation has set up a new research institute at Cambridge University, the Healthcare Improvement Studies Institute. And one of its work streams is around the development of citizen science, being able to crowdsource ideas, but also engage users, members of the public, staff in testing and in research as well. So I think it's a really, really exciting area. Well, I'm now going to move to ask our panellists, Anna and Amanda, for a final reflection on what we've heard today, because time's drawing to a close. So we're spoilt for choice in a way, but Anna, what would you take away as a reflection?
I think for me it would be about there's a real power in combining that kind of patient input with clinical input, with also technical knowledge about quality improvement, innovation, adoption and spread. When you get those three things going together under the care of a leadership system that supports that, you can really make great things happen.
And you've mentioned improvement a couple of times.
Yeah.
Is there a sense that actually there's a broader issue of improvement capacity and skills there that you can wrap around this to do good stuff? Yeah.
So with the Precept champions, for instance, we made sure that all of them had quality improvement training and all of them got a quality improvement coach. So it was really important, a part to recognise that if you're an NHS clinician and you've never had any training at all in quality improvement science before, how are you supposed to do some of this stuff? So there's a massive need, in my opinion, not only to get this embedded in clinical training as a core component, and I know the Royal Colleges are really working on this right now, but also for those of us that are at a later stage in our careers, how do we help us retrofit with these really important skills so that to keep up with the fast pace of change and the increasing demand for new innovation, that we can adapt in our roles.
Yeah. Amanda, a reflection from you.
Gosh, there's so much that we've covered. It's been really fascinating. I suppose from the NHS Innovations Accelerator's perspective, we don't just pick the innovation, we pick the fellow as well, and it is equally important. I think the NHS co-design, engagement, getting out to raising awareness of your innovation, it's all about people. It's all about people and relationships. So as well as having a great innovation, what we need to do is support people, both adopters and innovators, to think through about their own personal resilience, because it's hard work, it's lonely, there's multiple barriers, you'll have some really, really bad months, years even. And it's really, really important that you think as an innovator, as an adopter, how do you wrap support around yourself, feedback from people, having measures of success, so you can applaud that along the way, not wait for the year, a year end and have the outcome. But yeah, just think about your own personal resilience, because what you're doing is inspiring and amazing, but it's also really, really hard. So
yeah, and the NHS Innovation Accelerator is a really unique model, isn't it, in supporting not just the spread of a specific thing, but the individual as well.
Yes.
And what are the other components of helping through that journey? Because I know there's mentoring, is that right, as part of it?
Yes. So we are absolutely drawing on the expertise across the academic health science networks who have a great insight in their local systems and understanding who their stakeholders are, who the networks are, what needs are being addressed. So they have a technical as well as a social role. There's the amazing people, mentors. So I think I'm constantly inspired by and humbled by just how much time people give to support innovation, and they find it energising and they do it in kind. So there's lots of people that are offering support to the fellows. There's a small bursary, and as I said, one of the things that we have increasingly been doing is the kind of engagement of patients to help the fellows think through their approaches. I think finally the bit is comms and marketing. So I'd underestimated how important it is. Rebecca Taylor, our comms and engagement manager, is constantly challenging us. Why are you engaging? Who are you engaging, and why are you engaging? And explain your innovation to. Think you're talking to your friend's mum. How do you explain it in a really concise way? So I think I'd underestimated that technical expertise around comms and marketing.
It's fascinating to hear. If I had a takeaway reflection, I guess it would be something that's run through all of our presentations, which is that adopters play a critical role in the success of spread, both in the hard work they do to adapt interventions to new context and in all the learning they generate as well. And while it's right that we support innovators and pilots and demonstrations and so on, I guess it's critical that we recognise that role that adopters play and support them in the challenges they face too.
Absolutely. I couldn't agree more. I think there's something about being the first follower, isn't there?
Yes.
And then the subsequent next few followers that actually help improve the person that came up with the original idea. And we're not recognising that enough.
Well, I'm afraid that's all we have time for today. I'd like to thank our speakers, Amanda Begley
Thank
and
you.
Anna
Thank you.
Burhouse. Thank you so much for
Thank
joining
you.
us. And I'd also like to thank everyone who's joined us on the webinar today. I hope you found it useful and it's given you some food for thought. The webinar will be available to watch on demand, and we'll be in touch with you as soon as it's available. Thank you and goodbye.